Good morning. Thank you to everyone who has joined us for our third expert panel discussion. Today's panel discussion is going to focus on liberation from mechanical ventilation. And the first thing I like to do is introduce everybody. So, starting at the top, Tom, if you introduce yourself.
Here on mute.
My mic is muted. My name is Thomas Pereno. I'm a respiratory therapist in Canada, educator and consultant.
Andy?
Hello, my name is Andy Klein. I'm the Adult Clinical Education Coordinator at Rush University Medical Center in Chicago.
Madison?
I'm Madison Fatsky. I'm a respiratory therapist at UVA in Charlottesville, Virginia.
Karsten?
My name is Karsten Roberts. I'm an assistant teaching professor in Philadelphia.
Joe?
Jay Hilton, respiratory therapist, clinical applications for Hamilton Medical, and an RRT for Atrium Health in Charlotte, North Carolina.
Joel?
Joel Brown, respiratory therapist, CEO of Arrive Leadership, former hospital administrator.
And John?
John Ancroft, flight respiratory therapist, Advent Health Orlando, and adjunct clinical instructor for critical care paramedicine at University of Florida.
And again, my name is Keith Lamb. I'm a respiratory therapist at the University of Virginia, and I work on the trauma and surgical service there at UVA. A reminder, this hour discussion will be available for replay on our YouTube channel. If you don't know, the website is www.inspire-rt.com. So we'll just go ahead and get right into this. We've developed a couple of questions that we want to discuss regarding the ventilator liberation process. And so we'll start out with when to start the liberation process. And by the way, feel free to use the chat option to ask questions or make commentary. Karsten, you want to start us out with when to start the liberation process?
Yeah, sure. So I think that it's important to highlight, first of all, that there are three goals of mechanical ventilation. One of them being safety, one of them being comfort, and one of them being liberation. And this has been written about by various people over the years, but those are generally thought of as the three main things. So that means that the mode of ventilation that we set on a patient should be matched to whatever that current goal is. So if the current goal is safety, then we should be ventilating patients at 6 mLs per kilogram of ideal body weight. And if the goal is liberation, then we should have them set to some sort of continuous, spontaneous ventilatory mode. So in my mind, the process of liberation really starts at the beginning, as soon as the patient is intubated. But what we should be looking for in terms of when we should change from our goal of safety to comfort to liberation is when there's some reasonable resolution of the disease process that got them intubated in the first place. So again, I think it starts from the beginning of intubation, but we're really looking for some reasonable resolution of the disease process in order to proceed.
John?
Yeah, I think it's a kind of dovetail on what Karsten said. Clearly in my theater of operation, I'm not weaning anybody, but in the ICU, obviously, safety is key. But I think, what clinical indices are we looking at before we start to say, can we liberate this patient from mechanical ventilation? So I kind of agree with Karsten. Those 3 points, safety being key and setting up the ventilator correctly can have a lot to do with how we and when we are able to get these patients off mechanical ventilation. But ABC to EF bundles, mobilizing your patients if they're on prolonged mechanical ventilation, to make sure that delirium doesn't set in, because that can really cause a lot of issues when it comes to weaning. And collaboration, make sure that your interprofessional approach to weaning includes nursing, includes everybody that's going to have a part in this, because you're not going to be successful if you and the nurse don't have some sort of camaraderie to know when the SAT takes place, the spontaneous awakening trial, know when sedation is turned off, and how your patient's doing with it turned off. And those can obviously play a lot into how successful your patient's going to be. So my 2 cents.
Yeah, I actually was going to. Thanks for saying that, and I agree with Karsten. I think the big point, and that even take it further back, is that before you start your spontaneous breathing trials, is to make sure you have some protocols, some therapist-driven protocols that everybody knows. Make sure you have a standardized practice of how you're going to do it, because especially when you have folks that come from other organizations, and I know that there's a considerable amount of travel that happens now, that you never know what that person's baseline knowledge is or what they practice at the other space. So if you don't have the protocols, the RT-driven protocols within your organization, I highly, highly recommend it. It's good for our patients. It's good for our profession. But I think it starts from there, is the development of the protocol, making sure everyone's educated, just as John was saying, and not just the RTs, but the nurses and the staff, physician staff, so they know what to expect and what they should be hearing from us when we attend rounds, because that's the other thing, we always attend rounds.
I think it's important for those who do develop protocols and policies within the hospital as well to keep themselves updated in terms of what protocols are being used in current studies. So there might not be a study specifically on the best protocol or checklist, for example, but you should look at more recent studies and say, what was their protocol? How did they determine when it was time to perform an SBT? Because this SBT should be performed daily if the patient meets criteria. So what are the criteria being currently used? Because you might have this criteria checklist from 12 years ago, and maybe over time, certain things have been shown to not be very beneficial as a part of a checklist. Maybe the checklist has been simplified. Maybe things have been added. So it's always good to look at recent studies and say, what was their protocol to determine that SBT was basically readiness for assessment of liberation, which starts off with something like a rapid shallow breathing index, and then continue on with an SBT. And if you want, I can give an example of that protocol if you want. I have the Promising study is a study of pressure support versus PAV. And it's not, I think it's finished enrolling patients, but they had a very specific protocol for assessing SBT readiness, essentially, or weaning readiness. And it's very straightforward. I'm sure all of you can guess some of the things that are on it. Is your FiO2 below a certain level? Is your PEEP at a certain level? Are you on vasopressors? And actually, a lot of people used to have old checklists that said if they were on vasopressors, the answer was no. But now it's like if they're on a dose of vasopressors that below a certain level, it's okay. It's if it's above a certain level, maybe you want to hold off today. So it's important to be aware of what people are using.
Yeah, Tom, if you wanted to bring that up.
Yeah, I'll just pop that up on the screen right now, just so we can give an example. Again, this is just one study protocol. I'm showing this because it's clearly a recent study protocol, like it hasn't even been published yet. But essentially, it looks like this, where this is the part I'm looking at here, and this will be very straightforward for most people. Some people will have a saturation target less than. Again, some people may have a higher acceptance, like maybe 50%, but this should be similar to what you have as a protocol now. PEEP level. I know that hospitals I've worked at, it had to be PEEP 10 or less, but for this study, it was 8 or less. pH, they want to make sure the patient is, not in significant acidosis at the time. And then vasopressor requirements, it was okay as long as it's less than 0.1 micrograms per kilogram per minute. No respiratory distress. And then this was separately defined, just so you know, if you're going to put something like this into a protocol, make sure that somewhere on that same document, you define what respiratory distress is. And I don't have that readily available. I'd have to open up the other PDF, but also clinical instability was also very clearly defined. And it's usually defined with something like one or more of the following, or at least 2 of the following. And they might have a list of things that would be considered respiratory distress, but they have to meet at least 2 of those criteria to be deemed in respiratory distress. So that's just an example. And then if they meet the criteria, if everything in here is checked off yes, then for example, in this study, it says if the only problem up here is the PEEP is higher than 8, They tell it to try to go to 8 or less and check again after 30 minutes and see if they still meet criteria. Because to be honest, sometimes we're just too darn slow at weaning PEEP, right? So that if that's the only criteria that you haven't met yet, you probably should try adjusting your PEEP and just see what happens in 30 minutes. Assuming you're not on a PEEP of 20 on a morbidly obese patient who just got intubated. And then down here it says, perform a CPAP trial. So what they do is they put the CPAP to 0. Which still allows significant flow. It's similar to doing a T-piece. This is your RSBI. So for 1 to 2 minutes, looking at the frequency over tidal volume ratio. And then if it's less than 100, again, the typical cutoff has been 105. They use less than 100. If the answer is yes, it's less than that, and their SATs are still over 90, great. And again, no respiratory distress or clinical instability. Again, this is defined separately. Then sure, they pass the trial, go ahead and do an SPT. Now, for this study, it's T-piece or trach mask. For other studies, it may be 5-on-5. Again, we'll talk about the types of SPTs, I'm sure, in just a moment. But this is an example. And then, again, did they meet any of those other criterias? And then if so, then they didn't pass it. But if you answered no, in other words, they had no problems to all 3, then essentially you should be extubating the patient. And the next page is reason why they didn't pass the SPT. But here's another example here. Is the criteria still weaning present? Yes. Did they pass their SPT? Yes. Now we're talking about LOC and cough, etc. Because sometimes patients don't need a ventilator. They need an airway, right? Because they're not awake yet. And this is always the problem when we talk about liberation, is that they may pass every test known to RTs to liberate, but they're not awake yet, right? So they maintain themselves on ventilation because of level of consciousness. But anyways, I won't share the screen for too long. Just to highlight, a recent protocol. So you can usually find these protocols when you look up studies. You can usually look up what the protocols, particularly when they're published. They normally publish appendices that will, share their protocol for assessment, because again, the purpose of studies is that they should be replicated. You should be able to replicate them. So the question is, what did they use? What was their criteria? So you can usually find these protocols online.
In 2019, Brian Anderson published an article about early alert systems, and basically putting all the same criteria that Thomas just shared on to a dashboard in the ICU, so that everybody is alerted to when patients are ready to be extubated. And by using that early alert system, they were able to decrease mechanical ventilation by 1.5 days. So basically, when those criteria are all met, the bedside clinician gets an alert, an electronic alert that says that the patient's ready to be weaned. And the other thing that I would add to that is, and Thomas talked about it a little bit at the end there, is about sedation, and making sure that the patient's RASS is between -1 and +1, and so we're really, from a respiratory perspective, working with our nursing colleagues and getting sedation weaned at the earliest possible time in order for them to be able to tolerate spontaneous breathing.
Yeah.
I like to, sorry, go ahead.
Go ahead, Tom.
I was just going to say, I often like to really highlight the coordination that we need to have with the nursing staff, particularly. I know many people have heard of the mode Smart Care, and this is not a sponsorship by Drager, but it's a mode that automatically turns things down, and then if the patients meet criteria, it'll actually put them into an SPT, right? I know Hamilton has a similar type of mode scenario where continue to wean patients and then can apply an SPT. In all of the studies that were done on Smart Care, it showed that it was faster than a weaning protocol done by RTs, perhaps by 1 day. The one country where it didn't show any difference was Australia and New Zealand. And the reason is that the nurses maintain the ventilation and the sedation weaning. So the question arises that when you have someone who's actually responsible for both, coordination is not a problem, and therefore they can turn off sedation, do the tests that are provided, or the ventilator. They can watch the patient and then decide whether sedation goes up or down. So just understanding that coordination seems to make or to have benefit to ensure that your weaning of sedation and your timing for SPTs and checking for liberation is actually everyone's on the same page, essentially. So just to highlight what Carson said, like that RAS, like our RTs may be paying attention to RAS, but we're not often in control of the RAS when it comes to the sedation and the medication given to the patient.
It's probably the most important part is the communication piece.
Yeah, that study protocol that you showed, Tom, pointed out a couple of a lot of important things, but one or two things that I'd like to expand on a little bit. One in my practice and in my experience, delays can be caused by really subtle things. And one of those things is a miscommunication or misunderstanding for other plans for that patient during the day. As an example, I work in a trauma ICU primarily, and these patients have OR procedures that are routinely scheduled, but also routinely get canceled or bumped or postponed. And so a lot of the staff will, if not encouraged, a lot of staff will say, hey, this guy's going for a debridement this afternoon, or he's going for ortho surgery. So I'm not going to do the SBT, and we're not going to do the SAT because at 1300 they go into the OR, and then 1300 comes around and they don't go to the OR. And so nothing happens until the next morning when everybody is excited about doing SAT, SBT again. And so just by sort of a miscommunication or poor information, a patient could easily be intubated for 24 hours longer than they should have.
And Keith, can you define SAT for those who don't? I know it's like sedation vacation is what some people call it, but just in case, I know everyone knows that SBT is sort of the topic, but when you're saying SAT, I don't think that term is commonly used, at least in the ICUs I've worked at. We call it sedation vacation. I'm assuming you're referring to the same thing. It's like
so for us,
an awakening trial, essentially.
Yeah, spontaneous awakening trial for us. It's turn everything off that might sedate the patient. And then go back at half the dose that they originally were if they need to go back on sedation.
Right. Sorry, I didn't want to interrupt there. I just wanted to make sure that
that's a good question. And
I had to think about it for a second. I'm like SAT, and I'm like, oh, okay, I think I know.
I've actually had nurses
vacations
ask me what a SAT is.
Okay,
that's not better.
Yeah,
hey, it's where you turn all the stuff off and then turn it back on if you need to. But so I just want to point out that no matter how strong your protocol is, no matter how detailed it is, that sometimes things get derailed by the simplest miscommunication. So what I teach and what I recommend and what I think the literature suggests is that you do one of these every day, no matter what, right? No matter, even if you think that there's a possibility that the patient won't get extubated, you still need that information for when you're around with the rest of the team to recommend extubation or liberation or not. One of the other things that I wanted to mention is oftentimes I'll see a patient, we'll do an SAT, we'll do an SBT, we'll round, I'll give the information to the team. And then, so when they do their wrap up, they run the list is what we call it. They'll say something like, okay, so we're going to wean to extubate, and I have to interrupt and say, there's no weaning. They're ready. They've done their SAT, SBT. And so there's these little details that can sort of slow things up.
And I think we all, as RTs, need to be aware that sometimes the impression of what the patient needs versus what they're ready for is not, like, we sometimes let our own biases come into play. And I'll give a perfect example. And there's a publication, and I'll send a link to it. So we published, using the protocol that I showed you with the promising study, we actually published a paper looking at how many patients, when they were expected to be on the ventilator for at least 24 more hours. So let me back up. To enroll patients into the study for promising, we had to have patients that were going to be on the ventilator for at least 24 more hours, because we didn't want to enroll anybody into the study or randomize anybody into the study that immediately passed and was extubated, right? So you want to make sure. So we would approach the physicians, the people that are in charge of the patient, and say, do you expect this patient to be on a ventilator for more than 24 hours? So if they say yes, the patients can be enrolled in the study. In order to randomize them, we go through that checklist and we perform an SPT. Well, we published a study of over 300 of the first 300 patients that were enrolled into the study. Prior to randomization, 25% of them passed an SPT and could not be randomized into the study because they actually met all the criteria to not require a ventilator anymore. So this is extremely important that when we say, well, they're not ready for an SPT, is how do we know they're not ready for an SPT? Is it because we assume they need a ventilator for a few days? Like, we have to sort of get outside of the expectations and just, if they meet criteria, follow the protocol, perform it. If anything, even if your patient's just not awake, you may realize that they don't need a ventilator. So you could maintain them on very minimal settings, one that doesn't require them a lot of work, but also it sort of prevents atrophy, right? You don't want to over support someone who just needs an airway, because then by the time they wake up and they're ready to come off, you don't want to know that they have atrophy from over support. So it's important to perform these tests even when we have a bias that they're not ready.
Excellent point.
I'll share a link to that study.
And Tom, you make a great point there too, that sometimes, like you said, our bias is of patients that aren't ready, and looking back at your protocol, saturating 90% on, minimal oxygen and things like that. I think more and more what I'm seeing in my practice is people that are requiring high amounts of oxygen to maintain saturations are still being extubated and placed on other levels of support in order to avoid some of the ventilator related issues that they can have. So, for example, if you have someone that was pure hypoxic respiratory failure and was intubated, and now you've got them down to, let's say, 60% and a reasonable amount of PEEP, you can put those patients on high flow, high humidity nasal cannula and maybe extubate them a day sooner than if you waited until their FiO2 was down to 40. The COPD population is another one. Like, if we haven't quite gotten them stabilized from a blood gas standpoint, we can still put them on non-invasive ventilation for a day and maybe get them off the ventilator a day sooner for that.
This is such great conversation when it comes to bias, because this can lead, and respiratory therapists need to be advocates for their patients. We need to be in communication with nursing and with physicians when it comes to patient ventilator liberation, because our biases do get in the way, and that can prolong mechanical ventilation longer than expected. And not that this is happening frequently, but occasionally when I do get to the ICU, why is it that we don't extubate on nights? Why is it that we don't extubate towards the end of a day shift or something like that? I've had experiences where physicians will be like, well, they did well, we're going to rest them overnight. It's like, if they did well, then let's extubate the patient. If they need to go on some sort of support, like Andy just pointed out, he did high flow, non-invasive positive pressure, something else besides a tube shoved down their throat, then we can do that. But don't let our biases are less than stellar advocacy get in the way of good patient care.
Just to quickly jump in from the chat, somebody brought something up that's, I think, happens frequently. Letitia mentioned that in her facility here, there are RTs have other assigned areas, and the patient may not be able to thoroughly evaluate and manage a patient while on an SPT. And every situation is different. They have their own circumstances that come with them. But you could easily make the argument that if you screened your patient, they're on an SPT, that might be the most important patient in your hospital at that time. Because if you're able to get them off the ventilator, the downstream effect of that is going to be huge versus keeping that patient on, as Keith mentioned, for another 24 hours. And oh, by the way, they had an emesis event, they aspirated, now they have an aspiration pneumonitis going on. And now those days on the ventilator and the cost just went up. So some things to kind of keep in mind. Again, every situation is different, but
yeah, I mean, every situation is different, right? Because we often think about extubation being the goal of mechanical ventilation. We're going to eventually get this patient extubated, but not everybody gets extubated, right? Some people end up tracheostomized. And so really the goal is liberation from positive pressure and not necessarily extubation. So it kind of goes back to what Keith started this part of this conversation off with, what Andy highlighted in terms of other patients have other needs. We have other ways of oxygenating patients. And so even though we talk about it as like, we want to get this person extubated, well, maybe they don't necessarily qualify for extubation, but they do qualify for liberation from positive pressure.
Yeah, and the respiratory therapist, through the evolution of the respiratory therapy profession, I think, have become, or should have become, the best triage facilitators around, right? So, not knowing exactly what Letitia's, system is set up like, if it were me and I was covering a floor and covering an ICU at the same time, that patient that's intubated on a ventilator is probably my priority, and I would see that person. You would never hear me say, I don't have time to go see the intubated person in the ICU. You might hear me say, I don't have time to go do that Q4 albuterol treatment. That's not necessary anyway.
Yeah. I was kind of smiling because I just know that your preference is definitely the ICU. So, but yeah, I think, when it comes to, that comment about, having to be on the floors. And then I know there was another comment around, extubating at night. Usually what people's primary argument is around staffing, right? We don't have the resources to extubate someone at night because I'm the only, I'm on call and the physician, there's only a resident there. Or we don't have the staff to be there, in the ICU for a spontaneous breathing trial patient because we're also on the floors. The one thing I'll say, especially from an administrative standpoint, extubation data is really easy to obtain. Probably the easiest. Like how often are you doing it? So I would say for the person that has the split assignment, someone should be looking to see, do we have patients on spontaneous breathing trials the majority of the day? Like, are we extubating folks around the clock? And then starting to look back and see if the staffing is set up properly, that person shouldn't be pulled from the floors. Same thing when it comes to, the physician staffing, right? Which was primarily where I finished mine. Like if we're in a large trauma center, right? Should the physicians just be on call and outside, or should they be actively available? And I've been at 2 facilities where we actually added in what we called round the clock spontaneous breathing trials. So basically, if the patient wasn't ready in the morning because they had surgery or something else, we did it at the beginning of the 12-hour night shift, which would be like 7:00 p.m. with the expectation they'd be extubated in the a.m. The other part, that I found interesting is we often had the thing, oh, this patient's going to the OR. And sometimes for us, we just go, okay, then I won't extubate the patient. But the next question is like, what procedure are they having? Is it something that can't be, that they wouldn't normally be extubated post-op, or is it one that they're going to need to be intubated throughout? So I agree. Number one, it's the staffing, but also the further conversation afterwards. And for those who are out there, I know that it's hard to get data, but extubation data, easiest.
I just want to, one of the things that we're kind of talking about right now is barriers to extubation. I want to go back up because Daniel Hardy had a nice comment about patients, like morbidly obese patients that are on higher levels of PEEP. I'm pretty sure all of us have probably extubated patients that are on higher levels of PEEP. And once their reason for being intubated is reversed, they usually do okay. I was just curious if any of you wanted to kind of reflect on that as a barrier and how to work through that.
Yeah, so I was going to comment on Danielle's comment on the comment also, but I think these protocols, that I wrote an article years and years ago about the art and science of respiratory care, and the science is following the data that suggests that this person's got a higher higher probability of being extubated successfully without post-extubation complications. The art is to sort of fine-tune those things and individualize those things to the patient. So to me, and in my experience, and like Danielle, I've extubated people that had BMIs of 60 off of very high levels of PEEP. PEEP that has been determined by esophageal manometry to be the appropriate PEEP for that patient to mitigate chest wall elastance, right? So I think that everybody needs, but this is an ICU team conversation. Okay, understanding that in rounds, you discuss this patient with the team and you say, okay, I realize they're on 22 of PEEP. However, this is why they're on 22 of PEEP. And this is why I think that we should customize this person's liberation approach over, over what our standard is. Obviously, our standard's not to put somebody on a RSBI that's on 22 of PEEP right now. So those.
And I'm going to assume, Keith, that you extubated to some sort of post-extubation support immediately.
Yeah, so
with someone like that, yeah.
I empirically just anybody who's got a BMI that's that high, I empirically extubate to non-invasive ventilation. Yep. If there's some contraindication to NIV, then I would extubate them to high flow. I would extubate them to something that gives me options for support immediately instead of having to ramp up.
Anything that has the potential to decrease worker breathing, because that PEEP, if you couldn't wean their PEEP below a certain level, then clearly some positive pressure is assisting them to maintain comfortable worker breathing that they could maintain post-extubation, provided you provide them some bit of extubation support with some sort of respiratory support. Yeah.
Right. And you never know. I don't think you can really quantify the level of worker breathing that end expiratory pressure is affording an individual patient. You can guesstimate and you can do some measurements to use as surrogates, but you never know how much that small endotracheal tube is contributing to that process. And so that's why I just empirically extubate them to something. And sometimes they stay on that support very, very short period of time.
And I think in addition to that, positioning that patient's of huge importance.
Yes.
You lay them flat, it's going to be game on again. And then you mentioned the endotracheal tube. Folks tend to forget that with an appropriately sized ET tube for someone's body habitus, you've doubled to tripled their worker breathing out of the gate before we've done anything else. That's important to keep in mind.
Yeah, so I could probably write a case series up on this. I never have, but there's also another type of patient that is morbidly obese that does not appreciate just a little more resistance. And we have found that in the past, morbidly obese patients that don't pass our standardized liberation process. And so not just that they need more PEEP, but we have gone on to measure their airway resistance, and their airway resistance is exceedingly higher than we thought that it should be. And then clean their ET tube out, and then they've passed their spontaneous breathing trial. So there's another, if you think of a patient that's got a 60 BMI, let's say you've measured their transpulmonary pressure, they need 20 of PEEP, and they're still not doing that well from a liberation standpoint. You might want to measure their, break out. If you have to Google to remind yourself how to calculate resistance, then do that, but calculate the resistance. And if it's a lot higher than you would anticipate, then maybe they need their endotracheal tube cleaned out. That's for people who extubate patients on a regular basis, that every ET tube you pull out's got gunk in it. And everybody, the amount of gunk they have is different for every patient. And so that's just another thing, if their airway resistance is high and they don't have reactive airway disease, then that might be something that's holding you up from being able to liberate also.
And I just want to point out, because this gets brought up a lot, because we're taught as RTs that the endotracheal tube itself imposes excess worker breathing due to airway resistance. And for the points that Keith were making, this is an airway that has clearly build up, and it's like above normal resistance for that tube. If you have an appropriately sized endotracheal tube for a patient, this was actually studied in the 90s by Dr. Laurent Burchard and colleagues. They tested the airway resistance through an endotracheal tube, and then just through the airways post-extubation. So when we often get told that the endotracheal tube imposes too much work of breathing for the patient, so we should always give pressure support or always give ATC or something like that. When they studied it, when they took the tube out, the airway resistance through their trachea, through their airway, was no different than through the tube. So having someone breathe through a tube, the amount of resistance through an endotracheal tube is not dissimilar from the airways when you after extubation, keeping in mind that you're going to have some bit of edema and swelling because they've had a tube through the vocal cords. So the resistance is actually very similar. It doesn't impose a much higher. So when you're assessing for readiness to wean, the question of whether or not you use ATC or not, it's not based on evidence. It would be based on your own comfort or your own bias, but it's not based on evidence that the endotracheal tube is harder to breathe through than it is to breathe post-extubation. So just pointing that out. But you always need to investigate, is the tube itself, you think you have a normal sized tube in there, but then you take it out and you realize it was half occluded. So it is important to understand that patency of the tube is important, but the tube itself is not something to be overly concerned about. It's whether or not it's still patent is the important point.
Yeah, and some patients, have an AT tube that's not the appropriate size for that patient. Yeah. And
because they were difficult, they ended up with a number 6 and they're, 6 foot tall adult with a number 6 tube.
And that's the patient I usually put ATC on, although it may not be supported by evidence, but.
Yeah, no, but it makes the most sense because that tube will impose likely a higher work of breathing than a normal endotracheal tube for that patient. I don't want to miss some of these questions before we move on. Someone was asking, what's the role of PMUS and P0.1 in weaning and extubation? In what cases should we use these?
Well,
I have an opinion, but I'll wait if anybody else wants to say something first.
Why don't you take that, Tom?
Okay. In terms of readiness to wean, there is no evidence that we should limit or prevent any of the criteria I told you before. Those other criteria are do these patients meet criteria for the potential for taking them off a ventilator? Now, during weaning, if a patient is failing their SBT, generally, I'm going to say that most patients failing an SBT are likely failing it due to increased work. They can't maintain the work of breathing, so likely their PMUS would be elevated. So where I think I don't want to say the evidence because we still need further evidence that guiding mechanical ventilation according to these values is important. They definitely highlight that a patient is doing excessive work of breathing. So it may provide insight into why somebody's failing, but it shouldn't be the reason to not perform an SBT, for example. However, you can monitor. So if you know someone's PMUS is elevated, so just so you know, normal PMUS is 5 to 10. Let's say someone's PMUS is 15. If it's 15 and during the SBT it's 15 and after the SBT it's 15, this patient might be able to maintain that provided their respiratory rate is normal, there's not desaturating. Like, can they breathe this way? Having said that, they may be on a red flag alert if they have an excessive high PMUS. Just understand that this may become problematic. This is definitely the patient I would post-extubate to some sort of respiratory support. If the PMUS gets worse during weaning, again, if they're passing their SBT, but the PMUS is increased to something you're not comfortable with, it really highlights the fact that they probably need some post-extubation support, provided they're passing your normal SBT parameters. But in terms of engaging and using these values in the extubation criteria, I have not seen that as evidential proof that we should incorporate these, but definitely I love paying attention to these things. I would measure P0.1 and PMUS in many of my patients. And probably when someone is actively just recovering from something like ARDS and, you wake them up and they're breathing and they have excessive drive to breathe, monitoring this can help provide insights when patients begin to fail. There's some data in COVID patients where P0.1 above a certain level sort of predicted a recurrence where they needed to be fully ventilated again, right? Like they didn't get extubated. They ended up sort of going back to needing full ventilation, perhaps proning, et cetera. So these values can provide insight, but they shouldn't be part of the, should we try an SBT or not? We don't have evidence that should guide whether or not we do an SBT at this point.
So I'm pretty cautious when it comes to using values like that. There was a systematic review and meta-analysis of 11,000 subjects that was done in 2022, where the RSBI showed poor specificity when and and moderate sensitivity when used to be predictive of extubation success. So when we're looking at values like that, we could actually, they may not be of value, one, and two, they may actually, using those values or depending on those values to determine whether or not a patient's ready for an SBT or ready for extubation, actually may prolong mechanical ventilation, as you said, Thomas.
Carson, I think that's a good point, and we are actually looking at that at my facility, the use of rapid shallow breathing index, because that's something that the physicians and the residents and fellows have come to adopt basically as gospel. But I think what needs to be thought of there is the value that we've all lived by for forever, the 105, 106, whichever you use. That was actually when Martin Tobin sent that paper out, that was actually meant to be measured with a respirometer with no support, right? So when you're measuring rapid shallow breathing index and using that as an index to justify ventilator liberation, you may be doing it on 5 of pressure support and 5 of PEEP. Depending on what your institutional guidelines are. And if you're looking at a RSBI of, let's say, 98 on that support, that's not indicative of what the evidence showed when the original paper came out, which was with no support, keeping that under 105 or 106. So one of the things that was proposed by the smart people that I work with was maybe we need to test the number itself and say, maybe the number, or maybe the concept of rapid shallow breathing index isn't bad. Maybe just finding a new metric, a new number that applies to whatever level of support you choose to use, that is a better indicator of extubation success.
And it may very well be that PMUS and P0.1 are those indicators. We just don't know that yet, and they need to be compared. And I think that, importantly, to Tom's point of a couple of minutes ago, they need to be compared on and off pressure support, because PMUS is going to obviously change if you have the addition of pressure support during the SBT. So there is definitely more research needed in this area before we can actually say whether one of these. I think it's interesting. I think it's interesting to consider the future of lung ultrasound in this area, and there's been a number of studies published within the last couple of years looking at the combination of the use of the RSBI with lung ultrasound. A couple of those articles that I highlighted in a 2022 review of mechanical ventilation for the Respiratory Care Journal, where some of these indices in combination with the use of lung ultrasound to look at diaphragmatic thickness. And I know that that's something that you guys are doing up in Toronto and looking at specifically, do have potential, but again, we can't necessarily rely on them as the main parameter right now.
I guess I'll just add in, excuse me, the lean thought, right? So agreeing with Thomas that, I think that there's numbers that some of the stuff is, we have this love for our numbers and we have a love for tradition, but what we don't have is time, right? So it's like, if you have a number that you're using out there, especially like that you just know that there's probably no evidence, or you have that patient that was recently intubated a few days ago, and they've been relaxing on pressure support, like, why are we adding that in also? So I think we have to really go back and look at, our current protocols and go, like, what are the things that are there that we could remove? So you're not there just getting a number for the number's sake. I agree. If you have someone who's chronically ill, they had difficulty coming off the ventilator, that these things can help you trend things. But I think there is a little bit of just good old clinical assessment and understanding your patient that could supersede just another number.
Yeah, and currently, sorry, go ahead, Keith.
I agree 100%, Joel. And so that sort of, so I want to touch on the RSBI really quick. The data from Marty Tobin, less than 105, it's out the door, doesn't count, doesn't matter if you're on support. And so, we go over this in the ICU on a regular basis. I'll have somebody, you have a ventilator that dynamically reports the RSBI, and somebody will say, "Look, the RSBI is great." And I said, "Well, that's not really the RSBI. That's the RSBI on the support. But if you want to use that data, those numbers that you have all memorized, then they need to be off of support. I can go in and turn the pressure support up and make the RSBI better." And that's not what we're trying to do. But what I wanted to lead into, Tom, real quick before you make your point, is: does everybody even need this? Like to Joel's point, a patient got intubated for being oversedated. They got brought to the ICU. They got reversed, or they got tincture of time, and now they're not oversedated. Do we need to do an RSBI and a 2-hour spontaneous breathing trial? Or do you feel confident to use your assessment skills and your critical thinking skills and say, I'm just going to extubate them now?
So that before that you get started, I apologize. I think my esteemed colleagues here, I think the rest of my friends here online, I think we can put to bed the notion that every patient who has a successful SBT doesn't need a NIF, doesn't need an FVC, doesn't need a blood gas. That's where your clinical acumen comes in, and you look at the patient and you say, everything looks good. I don't think we need to do all these things that are patient subjective, like a NIF and FVC. Okay, sir, blow out the birthday candles. A lot of times patients can't do some of those things because they just don't understand what you're asking them to do. So successful SBTs does not necessarily indicate NIF and FVC. My opinion, what say you?
I'll just add that, and I agree, a lot of the complicated measures that we do don't help us to predict extubation success, particularly in a world where we have clinical guidelines that actually tell us to provide post-extubation support in patients who are high risk and even patients who are low risk. So, like, there's evidence of high flow nasal cannula post-extubation in low risk patients where the reintubation rate, was low in the control group that just got the standard of care, but it was even lower in the patients with the high flow. So they even found a benefit in patients who they weren't expecting to need reintubation. And in high-risk patients, the clinical guidelines already suggest using NIV and high flow nasal cannula. And particularly if you want to decide, well, should I give NIV or high flow? Because clearly one might be easier for you to set up than the other. One of the more recent studies looked at which patients did better with NIV, and it was patients who were hypercarbic. So although I agree that we don't need an ABG to determine extubation, a more recent ABG that suggests this patient has chronically high levels of CO2 may help you to determine what type of post-extubation support you provide this patient. And you might want to lean towards NIV if the patient has an underlying hypercarbia, whereas high flow nasal cannula would be beneficial in all patients post-extubation.
And that's understanding the patient's history when you put them on mechanical ventilation, that this patient might be a chronic, retainer or something of that nature. So when you do get to extubation, you may want to have a BiPAP just outside the door. So yeah, I agree, Tom.
And there's evidence. I mean, the guidelines that suggest using NIV post-extubation, one of the papers that was published years ago, I believe in Lancet, showed that for patients where the CO2 increased during their SBT, so they still passed it, but they were doing blood gases routinely. For those that increased it, NIV post-extubation was beneficial at reducing reintubation rate. However, those patients probably would have been identified anyways as high risk, and we have clinical guidelines to suggest. Now, high risk, I just want to try, Keith, because I know you probably want us to get back on track. I'm looking at the document to try to make sure we cover most things, because we sort of have. Two things we haven't. So one thing I think we established, but maybe some people watching didn't quite catch it, but the RSBI test, it's supposed to be a 1 to 2 minute test on no support, and this is where the value of 105 or less came into play, because I know many people do RSBIs on PEEP-5 or press support 5 and 5. The RSBI was not intended to have any support. The RSBI is also separate than an SBT. An SBT is a test to see of readiness that is prolonged. So the first 2 minutes is basically it's almost a qualifier for the SBT. So in that protocol I showed you, if the patient failed that 2 minute test, we did not proceed to an SBT. Now, again, different patients, obviously we have to consider if the patient's morbidly obese, they may not pass your zero SBT. So, or sorry, RSBI. I don't want to mess up my terms there. So, but for the standard population, performing an RSBI should be 2 minutes or less with no support if you want to use that number accurately. And I do agree when I can't remember who mentioned it, but maybe it was you, Keith, basically people watching the number as someone's on pressure support and like, oh, look at the RSBI. It's like, that's not the RSBI. I know the ventilator is telling you the frequency divided by tidal volume, but that's not accurately the RSBI. And just to answer Madison's question, we're awaiting the publication. The FAST NWC trial should be published hopefully soon. They are done enrolling, and they actually tested whether or not once the whole study was it's like a 4-part randomization. It's once versus twice day SBTs. So we will have data on whether twice a day is beneficial and gets people off ventilators faster. So part of the randomization was once versus twice a day. The other part of the randomization was pressure support versus T-piece for your SBT. So we'll have even more data on whether or not there's a difference between that. And both groups were given the same timing, et cetera. And after 30 minutes, both groups were assessed to see how they were doing through their SBT. So we'll have a lot of information from that one study because it was a four-way randomization. You either got randomized to once versus twice day screening, and then the style of SBT was also determined as part of the randomization. So it's the frequency and oh geez, I can't remember frequency and I can't remember what FAST stands for now. Anyways, that's what I just told you is what the study is going to tell us.
Yeah. So in the absence of any strong data to support doing multiple SBTs in a day, what I do, to me, it depends on why they failed their first SBT, right? If they failed because we didn't do an appropriate SAT and they're too sedate, or if they failed is a different patient than a patient that fails because they have significant pulmonary contusions and chest wall injuries and manubrium fracture and clavicle fracture and multiple rib fractures. If that patient fails their first SBT, then in my ICU, they don't get a second one that afternoon. We address the issues that are causing the patient to fail the SBT. And if we can find something specific and occult, then we fix that, and then we might do it again later in the afternoon.
So Sarah earlier mentioned a question about tracheostomy timing, and I feel like since this is ventilator liberation, we can't really not talk about it briefly. I think that one thing I was wondering if we could sort of just really quick touch on is the timing of tracheostomy in certain patients. What is all of your experience with, if a week goes by or 2 weeks, what does the literature support? And then what do we actually do at the bedside?
So I'm glad I'm glad that came up because I was literally thinking about that just before we got on today. So I did a quick little reading about it, and I think that this might be confirmation bias, but I think that what I read kind of highlighted how I feel about this, that this is an area which should be patient centered. What are the goals for the patient? These decisions for tracheostomy have to be individualized, in my opinion. And the quote that I read is that, that this debate is ongoing. It's been happening for a long time. Should we, there's some evidence that shows that, tracheostomy as early as 3 days can be beneficial to outcomes. But I liked the quote that said, patients want to thrive, not just survive. So again, it goes back to highlighting the idea that this decision needs to be individualized.
So to Carson's point, if you ask any ENT or most ENT physicians, when would you want to be trached versus having an oral endotracheal tube? They said 3 days. So, and being patient-centered, you look at the SCCM stuff that says, family involvement is key in your patient success from ventilator liberation as well. Don't drop the trach conversation on family 7 to 10 days in. This is a discussion that probably should happen at day 5 at minimum. And then again, who's to say, does it need to happen on day 5? Why can't it happen on day 1? Here's our goal. This is what we'd like to do with your loved one. Get them off as soon as possible and as safely as possible. But here's the worst case scenario. And you can prepare a family for the decisions that they may have to make for grandpa who's got COPD, who's intubated, who's not a DNR. So, the conversation should probably be had earlier rather than later. Don't drop this conversation on somebody at day 7, because then the family's like, oh God, what are we, what would he want us to do? What should we do? How's it going to be to take care of him? Is it permanent? They have a lot of questions too. So
Yeah, so many variables in the decision to tracheostomize somebody that are different for everybody. The goals of care, their wishes, their chances of being extubated successfully. The need for to partition the need for ventilation and airway. There's just so many variables. I would really find it hard to support a specific timeline that fits all, for sure.
Something else, Keith, and I don't know if any of my colleagues here are experiencing this in their facilities, but something we've been doing a little bit more of. And when I first started practicing, there wasn't such a thing, but we're doing these trial extubations on borderline patients where we've started to consider the possibility of tracheostomy. We know that they're probably going to end up there, but for whatever reason, they want to see them fail an extubation before they approach as you said, approach the family and have that difficult conversation of a more permanent surgical procedure. And so what are you guys seeing in your practice? Is this something that's picking up steam? Is this something you think we should be doing?
So I hear people mention this trial extubation quite frequently. I'm absolutely opposed to extubating somebody who I have a pretty good suspicion that they'll fail. I don't think it's safe. I don't think it's in the best interest of the patient. And so I recommend against that when anybody ever, if they don't at least, so in a neuro ICU that I work in quite often also, people will check, we'll be able to check the spontaneous breathing trial box. They passed our RSBI. We went on to do the SBT. They passed that, but their neuro status is horrible, right? And that's very frequent. And I always say, you don't have to be able to do the New York Times crossword puzzle to get extubated. You just need to breathe. The problem with the neuro patient is you don't know what their airway is going to do when you extubate them, and so that's where this trial extubation for us. That's where this trial extubation conversation comes in. But I'm almost always opposed to that approach. I'm not sure what else. Anybody else?
Man, Keith, I mean, when I heard that, and I've heard it before, my heart rate almost goes up. Like I can feel I was like, oh man, yeah, I agree. It's just, man, oh man, if you have a patient that is just not going to pass it, I mean, you're taking some major risk there. And I hope that you're excellent at maintaining your airways, and definitely difficult ones. And the neuro patient population in particular, like you said, sometimes they can maintain that airway, but they may not be able to clear themselves well. And, it just really would make me nervous. I would, from an administrator standpoint, I'd be trying to, if that was the normal practice, I'd definitely have to figure out how to make sure that we had some expert airway folks around at all times if that became normal practice. Yeah. And I know that that's probably all fear-based or seeing enough nightmares versus evidence, but that is just the initial response I have.
Yeah, I think everybody has to have their eyes on the patient. There's got to be consensus. The risk of extubating versus the benefit of extubating, the risk of tracheostomy versus the benefit. I think that everybody sort of needs to be on the same page. And some people are just braver. Some people are braver than others. I don't want to have a problem if I can avoid it. And when they fail, it's my problem. And so I just think that it's a conservative approach in that respect is better for me and better for the patient, maybe. Troy made a really good comment about reintubation rates that's worth addressing, and whether or not there's an appropriate reintubation rate or there's not. In my mind, the perfect reintubation rate would be 0. If the appropriate reintubation rate is 20%, that means that 20% of the time we haven't evaluated the patient well enough, or we've been surprised that if you're only extubating people that pass your test.
I think it speaks more to the sensitivity and specificity of the tests we're doing and in terms of predicting success, because we can't be perfect with everyone. So, I've heard before that if your reintubation rates are extremely low, your ventilation days are probably very long. Meaning you're waiting too long and you're not taking a chance on most of your patients. We do have an expectation of reintubation, but having said that, and Keith pointed out, the most recent SBT study as well, where what reintubation dates should be utilized. So historically, studies usually did less than 48 hours, but now they're doing up to 5 or 7 days. I know with the promising study I mentioned earlier, we were doing 7 days, looking at reintubation rates. So maybe on day 7 has nothing to do with the initial insult, but it's something to consider that maybe we need to look out further down, particularly considering patients are getting more and more post-extubation support. And I just want to point out that I did share links to the most recent guidelines for NIV and the most recent guidelines for high flow nasal cannula, both of which suggest immediate extubating patients to NIV or high flow nasal cannula does have clinical guidelines to recommend this practice. So I think oftentimes we extubate patients, we don't consider the fact that we probably should give them some post-extubation support. And then the question comes down to, when they fail later, what should we do? And I guarantee anyone who's worked clinically on this panel knows that patients that have failed 6 hours later, we've all been asked to put them on BiPAP or put them on high flow nasal cannula. And just so you know, the evidence does not suggest that that's actually the right thing to do. If someone fails 4, 5, 6 hours after extubation, so they're failing liberation, and you didn't provide immediate support, you're now being asked 6 hours later, the evidence suggests that that's actually more harmful than just reintubating them. So the guidelines don't suggest post-extubation failure support. So patient shouldn't be failing. It's a prophylactic is what's recommended. The recommendation for NIV post-extubation is a prophylactic thing. So you take the tube out and you're placing them on that post-extubation support. It's not something you have sitting and waiting for 4 or 5 hours down the road to then apply. So I did share the guidelines that do have that, or that recommend those.
And I think it's important for the team to focus on why somebody failed their extubation. If somebody fails extubation because of upper airway edema and they get reintubated for stridor and distress, addressing that with steroids for, whatever your du jour cocktail is, first before you try it again is important too. If somebody fails because their volume overloaded and you didn't think that was going to be significant, but it turns out that it was, then diuresis, et cetera, positive pressure for a period of time and over sedation, whatever the reason was for the failure.
I also want to be conscious of the time. We're now at an hour, but one of the things we haven't addressed is what technique should be used for a spontaneous breathing trial. And we won't get too far into it because we don't want to put too much pressure on Karsten, but there are clinical guidelines that are being published. They were accepted for publication, but Karsten can't say anything about it. So we can say all we want about what we think, but Karsten actually was the lead author on. Did you worked with others on this, correct, Karsten? Or was it a solo event?
Yeah, I don't think that's a possibility. And
I was like, that wouldn't be very nice to do to you.
Yeah, so we have 11 co-authors on it. I'm the lead author. Our senior authors on the project were Tim Gerard and Neil McIntyre. Dean Hess is also an author, as well as Linda Goodfellow, and we have a whole really great team of people that worked on this project. So we answer in this guideline that's going to be published hopefully in the next couple of months, we had 4 PICOs that are being answered. One of them being, does including an RSBI predict the successful completion of the SBT? One of them is, does the pressure support increase SBT and liberation success? Does the time of day or night for the SBT affect successful liberation? And does the increase of FiO2 during an SBT increase the successful liberation? So a lot of that we already kind of talked about through most of this conversation. So like you said, we don't have to go too deep into it, but we also just started working on another set of guidelines that'll be published hopefully next year, that look at some of these other questions that need to still be answered. Should we be doing SBTs for 30 minutes or 120 minutes? Should we be extubating to NIV versus high flow nasal cannula? And you shared the guidelines from the ATS and this other high flow nasal cannula guidelines, but we're asking this question of which one is it? These are different guidelines for NIV versus high flow, but we want to combine those into one thing. We also look at, for those neuro patients that Keith was talking about, one of our questions is, at what level is there reduced risk of reintubation on the Glasgow Coma scale? So a lot more to come. I think that, like you said, the FAST trial is going to be a big deal for answering 2 of the questions, not answering. I should say
contributing to the evidence.
Contributing to the evidence for 2 of our questions from this first CPG that's going to be published in a month or 2.
Yeah. And it's important for readers to understand that these CPGs, because I've also been part of publishing CPGs. When we say we're answering PICO questions, sometimes the answer is the evidence is not that great, so this is just what we're going to suggest. So it's important to understand that when you read the answers to these PICO questions in the clinical practice guidelines, that many of the times when the evidence is weak, there will be a level C or whatever scale you're using to evaluate the evidence. A lot of the time we may have to come up with suggestions based on very weak evidence, and it becomes almost an expert panel discussion or opinion based on the very weak evidence. So we can't make strong recommendations. And the important part about that is that if a study is published that is done well and actually adds to the literature, as Karsten is suggesting, that it may actually change the guidelines. And this is when these guidelines need more regular updating, is when you get a significant study that adds a significant amount of certainty in your assessment. But for many, because I was the first author on the oxygen guidelines for adults. It's like, well, if you look at our PICO questions, most of them are grade level C in terms of our recommendations, because the evidence is not that strong one way or another, depending on the PICO question that were answered. So it's important to understand that in case you read the guidelines and it's totally against your bias, look at where they got the information and how strong the evidence is, and just understand that, if their overall consensus was to give a certain recommendation, you may want to consider that even though the evidence isn't strong for one side or another, the majority of it sort of leans a certain way, and perhaps you should consider that. And especially if it's against your bias, you might realize that maybe we're doing things not the way that the evidence is moving us towards. But always be prepared for things to be updated when data is updated, obviously.
I think importantly, it also adds to the opportunities for future research. So,
absolutely,
if we don't come up with recommendations that are, in line with what your current protocols are, perhaps the protocols need to be changed. And that in itself also leads to more research. So when you change a protocol, collect data and see if that actually worked. And that qualitative evidence that you gather, can lead to, or, to further evidence that supports the literature later on when those CPGs are updated.
Particularly if you're in a hospital where you're going to change your guidelines to be more in line with new clinical practice guidelines, it's an amazing opportunity to do some very, single center qualitative research, just, when we changed to follow the most recent clinical practice guidelines, were there any changes in outcomes? Just making sure that you define what those outcomes are that you're looking for before you start looking at the data, rather than looking at the data and then determining what your outcome should be. You should always determine this sort of, pre-study, say, okay, if we're going to change our guidelines, what are we expecting? And then you collect the data prospectively, and then you compare it to the retrospective data, but making sure that prior to doing this, you have this established goal of what question you're looking to answer within your own facility, and then see if your data supports it.
And when, just one more thing, and when there is sort of a paucity or a lack of robust data to use a specific approach, like I think is the case in some other things we're talking about today, we'll find out. But I think it's important that you're consistent. So if Tom comes in and does an SBT on a patient today, and I come in tomorrow and do one, if we take two different approaches, then we're not really sure if the patient's getting better, getting worse, or the same. So I think it's important to be consistent. So with that, I think unless anybody has any last words, we will close this panel discussion down. Again, it will be available on our YouTube channel sometime today, probably. And we appreciate your participation. We appreciate the expert panelists, and we will send out something with our next topic soon. So thank you all. Really appreciate your efforts.
Thanks, guys.
You're on mute.
I'm just adding one more comment. Someone was saying a topic idea, when to use high flow or NIV. Again, during respiratory failure is one thing, but I just want to highlight that to answer that question for post-extubation, those links for the current guidelines are there. But in terms of like what to choose when your patient's in distress, that's a decent topic. But I just wanted to make sure that people weren't confusing that topic suggestion with the extubation one. So I did suggest to Patrick to look at the links, but that was just for that high flow versus NIV in terms of like when to do it or how to make the decision. For what we're talking about today, that data is sort of in the guidelines already in terms of whether or not you should use NIV or high flow post-extubation. The answer is yes. And then, but moving forward, we can have another discussion. Okay, I'll end the stream. I think the chat might stay active for a bit longer. I'm not entirely sure, but thank you. And thanks, Keith, for being the gracious host that you are.
Thank you. Thanks for
Are we off? Are we off now?